I will discuss the results of CCC19 and TERAVOLT that have been presented during the ASCO Clinical Science Symposium. CCC19 is a large cooperative cancer consortium finally assessing the incidence of mortality in cancer patients who got COVID-19. And TERAVOLT is an international consortium assessing the mortality in thoracic cancer patients. In the CCC19, we have 928 cancer patients with any cancer type. Specifically, 21% are breast cancer, 16% prostate, 17 are hematological malignancies, and finally we have 10% of patients with thoracic cancer and 12% with gastrointestinal malignancies. In the TERAVOLT trial, we have 400 patients, all of them with thoracic malignancies. Let's go to the mortality. In the CCC19, we have 121 patients who died due to COVID-19, with a mortality rate of 13%. And of this 13%, 12% of them underwent mechanical ventilation, and 14% had an ICU admission. When we evaluate factors predicting mortality in the context of the CCC19, we have finally specific factors that are age, so elderly patients have higher risk respect to younger patients. Performance status, a performance status equal or more than 2 may increase the mortality rate. Multiple comorbidities, and finally an active cancer and a chemotherapy ongoing. If we go to the TERAVOLT trial, with a median follow-up of 33 days, 141 patients died. It means the mortality rate in the TERAVOLT is 35.5, higher respect to the CCC19. The hospital admission in the TERAVOLT trial was 78.3, ICU admission was 8.3, and patients who underwent mechanical ventilation was 5%. So there is a clear difference between the CCC19 and the TERAVOLT trial, since much more patients in the TERAVOLT have been hospitalized, but less patients have been hospitalized in intensive care unit. Why this? Maybe because patients enrolled in the TERAVOLT are much more European patients, and specifically much more Italian patients, where the ICU admission was conditioned by the high rate of infected people with COVID during the time frame of accrual, and so less availability in intensive care unit for patients with multiple comorbidities, with older age, and with higher performance status. So overall, I believe the lessons that we had from TERAVOLT and the COVID and the CCC19 trial was the following. CCC19 and TERAVOLT are the largest real-world data set investigating the risk of death in cancer patients, and in both studies, independent factors associated with increasing mortality were older age, number of comorbidities, ECOG performance status 2 or more, active cancer, and chemotherapy alone or in combination. Of course, we have still many open questions from these two real-world data sets. The first one is if cancer care prioritization or care intensity optimization should be based by COVID R0 index. So you know very well, if you have a COVID R0 less than 0.5, that is almost normal, maybe cancer care and access to intensive care unit can be quite normal. But while you increase the R0, of course, intensive care doctor will do a triage, and I am quite sure will give probability of access to intensive care unit to patients with better performance status and less comorbidities. And finally, the open question that we still have to answer in this context is to understand if we should test for COVID all patients with cancer, and if we should do a longitudinal serological study for all patients in order to test IgG and IgM.